Hello, students. Welcome to part 2 of chapter 22. Now, we're going to start talking about general dietary management. Initial intravenous fluid and electrolytes. Okay, so it's basically all the knowledge that you need to know in order to work in a hospital. Routine IV fluids supply hydration and electrolytes. They cannot sustain energy and nutrients balance, right? Um, for example, a 5% dextrose solution with normal saline, okay, contain only 5 grams of dextrose. For clients receiving only IV fluids, the return to regular food should occur as soon as possible, and that's good to know. Patient must return to regular oral diet to stimulate the gastrointestinal, okay, immediately when they have their GI ready and they are functional with the functional GI. They must return as soon as possible to oral regular oral diet, okay. So there are some controversy in terms of dextrose, for example. There's, for example, for cancer patients, and that's something we're going to see in the next chapter. Cancer patients, we know in theory that cancer survives due to fats and sugar, right? So many patients that are receiving IV are receiving dextrose. Okay, think about it. So there is a controversy between the benefit versus risk of this type of IV. Now, for further focus, enhance recovery after surgery protocol. So this is a protocol that decreases the physiologic stress of surgery and promotes a faster and easy recovery, right? So ERAS eliminates the midnight fast and even recommends drinking high carbohydrates beverage before the surgery. Clients drink a clear, carbs-rich beverage on the night before surgery and another high carb beverage 2 hours before the surgery on the day of the procedure. This carbohydrate containing beverages reduce thirst and hunger and appear to have other metabolic benefits. Allowing people to eat and drink puts them in an anabolic, and we already reviewed the concepts about catabolic and anabolism, right? Rather than catabolic state before surgery. So catabolic is the metabolism, right? The destruction, and anabolism is the buildup of new tissue. So when the patients are having this type of nutrition, the high carbohydrate, they are in the anabolism state, right? After surgery, caregivers may begin feeding patients within 12 hours, and most people tolerate feeding well. So as you see, there is still controversy, right? Some people, they said, okay, try to be NPO 12 hours before the procedure. Now they are saying that based on this protocol, they are expecting the patient to have some type of high carbohydrate. Methods of nutrition support. So we have oral, we have the enteral, that we know enteral refers to the bowels, right? Nourishment through the regular GI route, either by regular oral feedings or by tube feedings. However, in medical nutrition therapy, enteral feedings imply tube feedings, okay? And then parental, nourishment through the veins, either small peripheral veins or large central vein, bypassing the GI tract. And now we have the oral feeding, and that's good to know if the patient has functional gastrointestinal. Oral is the preferred route of feeding. Remember that. And early nutrition of oral feedings within 24 hours after injury, surgery, or hospital admission is associated with reduced complication and infection, and in some cases, reduced hospital stays. Patient begin to consume clear or full liquid and then progress to a soft or regular diet as indicated. Caregivers may add supplemental nutrition drinks such as Boost or Ensure with or between meals or improve oral intake. So in this table, we have the conditions that often require nutritional support. For example, recommended route of feeding, you have the enteral. An example for the conditions are cystic fibrosis, neurologic disorders, congenital anomalies, okay? So they have impaired nutrient ingestion. And cystic fibrosis is a genetic disorder in which the lungs and the digestive system get clogged with mucus. Okay, that's why pulling sometimes is good. It's a good practice. Pulling is a practice from Ayurveda, from Hindu medicine, where you put a certain amount of different oils. In my case, I practice that with organic coconut oil, and I switch in my mouth for 20 minutes, and then I get rid of the coconut oil, and then the mucus is going to come, and it's going to clean not only my throat but my ears, my nose. It's amazing, especially for patients that had COVID. Is very helpful, or any kind of flu, right? Then Enteral also is going to be good for hyperemesis gravidarum, which is people that are pregnant, okay, and they are having persistent nausea and vomiting occurring during pregnancy. And then some other people, like severe gastroparesis, is often caused by damage to nerves that stimulate the stomach muscle. So myasthenia gravis also is another neurological disorder that we're going to review and study in depth when you come to me in 201 in the fourth semester. Now we have also the parental nutrition that is given through the veins, okay. Gastrointestinal incompetence, when the gastrointestinal system is not working in case of intestinal atresia, severe liver failure, intestinal infarction, obstruction in the lower gastrointestinal, and then critical illness with poor enteral tolerance or accessibility. Those patients with major trauma, bone marrow transplantation, think about them. So they need some type of food, and that's when enteral is coming into play. So enteral is very rich in carbs and protein, and is sometimes causing hyperglycemia. Okay, this is the criteria for selecting a nutrition support method. The physician and registered dietitian will decide the most appropriate methods of medical nutrition therapy for the patient with the use of the following criteria. Either the pharmacist or the dietitian will make the calculations for the enteral formula or parental nutrition. So for the enteral support, indicated for patients with the following characteristics, and you have here the definition, the criteria. That's basically for you to review. I'm not going to be testing you in this because you are not a nutritionist or a dietitian, and you are not the one in charge to make the calculations. Now, parental support, here they are unable to meet nutrition needs after 7 to 10 days of enteral nutrition. So this is basically one of the most important criteria. If parental nutrition support is necessary, the healthcare team must then decide on the specific location to administer the nutritional support, because you need to decide where the IV for this specific nutrition is going to be inserted, right? If this therapy is going to take less or more than 14 days, and for central parental nutrition, they are going to use a main artery, right? Um, Routine house diets after texture modification ranging from clear liquids and to full liquids, right? After surgery, patient is first on liquid diet, and then little by little they advance to regular diet. This can range from low sodium, low fat to high fat or high protein, depending on the client's needs. Therapeutic soft diets help the clients to transition from liquid to regular diet. And then assisted oral feeding, in which the caregivers can provide plate guards or special utensils to facilitate independence, which is very important. Small actions such as cutting meat or buttering bread before bringing the tray to the bedside promote feelings of independence. And when we work with this type of patients, we not only need to think about the feeding they need, the amount of nutrition they need, what type of nutrition, but also we need to think about the psychological part. Patients, they want to be independent, right? So the more independent they are, the better they feel they are going towards full recovery. Okay, so even if they get dirty trying to eat, trying to put some food in their mouth, let them be, because that bring happiness in the way for their recovery. Enteral feedings, when a client cannot drink or eat, but the remaining portions of the GI tract are functioning, right? They cannot eat or drink. For example, a patient that is having any neurological condition in which they cannot swallow, or there is a problem in the esophagus or the throat. Okay, but the remaining portions of the GI tract are functioning. An alternate form of enteral nutrition delivered to the GI tract tube provides nutrition support. Enteral tube feedings preserve gut function and are less invasive and less expensive than parental nutrition. If a client requires enteral tube feeding for a short time, less than 4 weeks, a feeding tube is usually inserted into the stomach through the nose, and it's called nasogastric, right? Nose, gastric is the stomach. For clients who are at risk for aspiration, reflux, or continual vomiting, a nasoduodenal or nasojejunal tube may be more appropriate. So that's good to know. Nasojejunal tube is indicated for patients for risk of aspiration. And now I have to remind you that our small intestine is divided in 3 parts, and I usually remember that as DJI, right? D as duodenal, J jejunal part, and I ileum. So here you go. So the patient is going to have the nasoduodenal, which is the first part of the small intestine, the duodenum, or the nasal jejunal, which is the large part of the small intestine, right? That is going to bypass. The food is not going through the duodenum, it's going through the nasal jejunum. Okay, so in both cases, a practitioner passes a tube through the nose and then down the esophagus and into the stomach. We have to verify the correct placement of the tube. That's very, very important. A healthcare practitioner will use one of the following methods: radiography, auscultation, or gastric content aspiration. And I'm sure you're going to learn this in your labs. You're going to learn how to verify for a placement. And then we have this table in which you can learn and see the route of administration algorithm for nutrition support. They are talking here about the parental, right? So you can decide, for example, here contraindication to enteral nutrition. If there is a yes, then we are going to use the parental route. If there is a no, we are going to use the enteral nutrition. So everything is based on the GI function to decide, either or. Routes: the patient disease state, estimated length for enteral therapy is going to be critical for taking the decision. In many clinical situations, using the nasoenteric route for short-term therapy of 4 to 6 weeks. When I say nasoenteric, we are talking about the small intestine, right? For long-term feedings, however, an enterostomy, right, the surgical placement of the tooth at progressive points along the GI tract, provides a more comfortable route as follow. So types of enterostomy: you have the esophagostomy. The surgeon places a cervical esophagostomy at the level of the cervical spine to the side of the neck, and after head and neck surgeries or traumatic injury. And then you have the percutaneous endoscopic gastrostomy. If the client is not at risk for aspiration, the surgeon will place a gastrostomy tube through the abdominal wall into the stomach. And then you have here different routine hospital diets in this table 22.4, and we have the type of food, the clear liquid. You see how the patient is advancing from clear liquid to full liquid to mechanical soft, meaning mechanical soft that the GI is functioning, mechanically functioning, okay? So we have soups, cereals. Cereals are going to be included, right? Not only in the mechanical soft, okay, cooked cereal, okay, but also I want you to remember that cereal are good for patients who can take oral diet post-surgery, okay, but also cereal could be used in full liquid and mechanical soft, okay. Cereals can be used in full liquid and mechanical soft diet, okay. Because cereal, when it gets in contact with the milk, is going to be very soft, like a puree material, right? So it's going to be included in full liquid or mechanical. And another concept I want you to remember is, that's good to know, puts patient in puree diet are still in full liquid. Okay, puree diet is still full liquid. Puree diets are not part of regular oral diet. Okay, you don't see puree in mechanical soft. Okay, so you have your bread, protein, vegetables. If they are juices, a vegetable juice or puree vegetables. Okay, now assisted oral feeding guidelines. This paragraph here is something that you need to know. So we have assisted oral feeding guidelines. Have the tray secure place within the client side. This is safety, safety, safety. Okay. Sit down beside the bed if this is more comfortable. Now offer small amounts. Allow ample time for a patient to chew and swallow. This is extremely important. So all this knowledge in this paragraph is related to safety. And as I told you, safety and nursing interventions are NCLEX alert. Okay. Offer liquids between the solids with a drinking straw if necessary. Let the client hold his or her breath to promote independence. Warm the client that sipping soup through a straw feels particularly hot. And all these type of guidelines that are going to help you to understand what is safety about when you are assisting a patient in feeding. So here we have a very nice graphic that is going to describe types of enteral feedings. A is a non-surgical route access through the nasal cavity, right? So it's gonna go through the esophagus, stomach, and here is the nasojejunal. Over here is going to be the nasoduodenal, also the nasogastric, and letter B, surgically placed feeding tubes, where the tube is not entering the nose. They are just doing ostomy, an opening in the esophagostomy, for example, in the esophagus, or nasogastrostomy. There is another opening here in the stomach, or the jejunostomy. Okay, so it all depends. Basically, for patients, it's more comfortable to have the second type, right? The ostomy. But this is more expensive, and the tubes are more uncomfortable. So, but they are less expensive. It takes a lot of dexterity to place the tubes, and you must learn about the location. Percutaneous endoscopic jejunostomy, the surgeon will place a jejunostomy tube through the abdominal wall and put it through the duodenum into the jejun, right? So you have the percutaneous. Enterostomy procedures may be good options for patients with gastroparesis, meaning that the gastrointestinal is kind of dormant, is not working, right? Gastric obstructions, or a history of reflux or aspiration for those who otherwise cannot tolerate gastric feeding. So, formula: the physician and the clinician dietitian, in accordance with the client nutritional needs and tolerance, usually prescribe the EN formula, right? The Entero formula, the enteral nutrition, in addition to the specific and immediate needs of the client. Other considerations include pre-existing conditions, comorbidities, food allergies, and food intolerance. So several varieties of commercial formulas are available and designed to meet individual needs. Polymeric formulas, for example, which are composed of intact nutrients, are appropriate for for use in clients with a fully functioning GI system and is capable of digestion and absorption. That's the case of polymeric formulas. And then we have absorbable hydrolyzed elemental or semi-elemental nutrients, and still others are a mixture of single nutrient modules of protein, carbohydrate, and fat combined as calculated by the dietitian. That means that some patients are going to get formulas more on the side of protein, some others more carbohydrate oriented, more fat oriented, right, to meet a client's specific need. I want you to remember that commercial formulas are they have less risk for infections, right? And we are going to read this paragraph. Provide a nutritionally adequate sterile, that's why they are having less risk for infection, homogenized solution suitable for small bore feeding tubes, okay? For small bore feeding tubes, commercial formula with sterile, less risk for infection. However, an increasing number of clients would like the option of formulas made from whole foods that are plant-based and organically grown, and that's their right. The patients can decide what they want to eat, but formulas such as these are commercially available and are safe for enteral use, right? Clients and caregivers may prefer the use of homemade puree table food for tube feedings. However, puree food may present the following problems, and that's something that the dietitian needs to discuss with the patient, right? The physical form: foods do not pass through the small feeding tubes because they are very thick. easily, and thus require the use of the uncomfortable large bore tubing. Okay, so that's one of the problems. They are very thick. Safety. Blender mixed formulas carry problems of bacterial growth. That's why the commercial is preferred, because they are sterile and they are less risk for infection. And digestion and absorption. Puree foods require a fully functional GI system, okay, to digest the food and absorb the release of nutrients. Enteral feeding formulas are available in varied caloric densities, and you need to be familiarized with this, all these concepts we are reviewing here, because you are going to receive every day in every shift. Somebody is going to have a nasogastric tube, is going to have a ostomy placed somewhere in the gastrointestinal, through IV. You really need to be familiarized not only about the concept of this, but how it works, how you should administer, what is the speed, what tricks on how to administer when it's a very thin a tube versus a very large bore tube. If the tube get clogged, all these problems you're going to start seeing in the clinicals. You're going to learn tricks. So the formulas provide carbohydrates in the form of sucrose, maltodextrins, or corn syrup. Protein is derived from soy, casein, or whey protein, and fat is usually from soy, canola, corn, or safflower oil, or medium chain triglycerides as syndicated. And we have reviewed all these concepts. We have talked about sucrose, we have talked about corn syrup, some of them are genetically modified. So these are the things the patient's going to get in the hospital, right? We spoke about fat, triglycerides, right? Some formulas also have added fiber. All formulas are fortified with essential vitamins and minerals that will meet the daily recommended intake in amounts commonly prescribed. So specialty formulas include those that are designed for patients with diabetes, okay? So probably the dextrose is going to be less in the formula, less present. Patients that are having trauma, that they need maybe more protein. Patients that are having cancer, more protein as well. Renal conditions and pediatric conditions, right? So it depends on the condition. Methods of administration, we are going to see continuous cycling, intermittent, and bolus feeding. So first, we have to check the condition of the patient, the condition of the GI tract. Is it functioning or not? Where are we going to place it? Via nasogastric, or is going to be via an ostomy? Now, what type of formula the patient is going to have? Now we are deciding, is it going to be continuous administration? Is it going to be cyclic? Is it going to be intermittent or bolus feeding? So you see all the considerations. Calculating a tube feeding needs and is a schedule for a person receiving enteral nutrition requires the following information: the energy needs, and we are going to consider the basal metabolic rate. We are going to consider the type of formula, the total volume, and the volume of formula to be provided at each feeding. Now, critical thinking: how many millimeters of formula does the following woman need at each feeding? And here there is an exercise for you to practice. And then the steps: calculate her energy needs. Also, I provided you with a website where you can calculate, right, the need. Now we are talking about continuous feeding. When the feeding is continuous, provide the enteral over a 24-hour period with assistance of a feeding pump. The pump is set to administer the formula at an hourly rate. But the problem with the feeding pump is that even though is doing our job as a nurses, the problem is that anything can change in the status of the patient, and then the machine can get broke, or maybe the tube is gonna get clogged. So we need to really follow up, and we need to monitor. Pump-assisted feedings are appropriate for critically ill patients to allow for the slower administration of continuous feeding into the small bowel. Critically ill patients are those who have not been fed enterally for some time, may not be able to tolerate large feedings. So we have the cyclic feedings using a feeding pump over a period that is less than 24 hours, and that is the difference between continuous and cyclic feedings. Then you have the intermittent feeding, is the administration of enteral over 20 to 60 minutes every 4 to 6 hours. And then you have the bolus feeding, are the administration of the enteral over a few minutes using a syringe or gravity drip. I've seen this one very often, especially when the patient is having good GI functioning. However, bolus feedings are easy to administer but may increase the crying risk for aspiration. That's why you need to assess very careful. The team needs to assess, right? The doctor, the nutritionist, the surgeon, the nurse, if the patient is able to handle this type of feeding. And that's good to know. NCLEX safety alert, because we need to prevent aspiration. Monitoring for complications. So now we need to monitor for diarrhea, right? Bacterial overgrowth, that is in relation to the type of food and the diameter of the tube that bacteria can grow there if the food is stuck in the middle of the tube. Infections or conditions that predispose the client to diarrhea. Before making changes to the enteral feeding protocol, the healthcare team should rule out the common culprits such as medication and Clostridium difficile enterocolitis, C. diff, right? That's good to know. Safety alert, NCLEX alert. And then we have the volume-based enteral feeding that I want you to review. Hospitalized patients often do not receive the full volume of enteral ordered by the physician because of interruption from tests and procedures that are part of their care. They are going back and forth from the unit, right? So volume-based enteral feedings follows the nurse to adjust the hourly rate of the feeding to achieve the desired daily volume. So these are considerations that you need to remember, and you're going to see them. You need to adapt. So the patient is going to go through different procedures, is going to have different situations in which the feeding has to stop, and then the volume is going to be at risk, the volume of administration, and the needs are going to be at risk, right? Ongoing research will help determine if these methods of volume-based tube feeding improve patient outcomes for all patients, or if there are certain conditions that preclude the benefits. So basically they are still monitoring how to do the feeding in a better way so the patient can receive the full volume. Monitoring the patient who is receiving enteral nutrition. We need to have the nutrition related history, the energy intake, the diet, macro and micronutrient intake. This is basically also blood work that needs to be done in terms of mineral, right? The medications. Also, we need to review the anthropometrics, and we review this concept in previous chapters, right? We have to check the weight, the length of height in pediatric patients, the weight change, physical assessment, and here the nurse is taking an important role, your signs and symptoms of edema to see if the patient is having enough protein or albumin through the feeding, the fluid balance, okay, the adequacy of enteral intake, the GI motility every 2 hours to 4 hours during initiation of feedings. We have to check for the tube placement. Biochemical measures, we have to check the serum electrolytes daily until it's stable, and that is done through blood work, right? We're going to check the sodium, the potassium, the chloride, the magnesium, and all these electrolytes that are going to, the calcium, right, that are going to be tested in blood work, right? And that's important to follow. And then problem solving tips for individuals receiving enteral nutrition. So the problem is, if the problem is thirst and oral dryness, right, we have to lubricate the lips. We have to choose sugarless gum, right? If the problem is tooth discomfort, which is going to happen, we have to gargle with a mixture of warm water and mouthwash. These are things that's good to know, and NCLEX alert as well, because that's part of your nursing intervention. So our job as a nurses is minimize the discomfort, okay, to the patients, and also we have to intervene to provide comfort, not only the pain. That's one of the things that we need to monitor, pain, to make the patient comfortable, but also in terms of feeding, we need to make them happy. It's not easy to have a tube feeding, right? Nasogastro tube, you have to check if the mouth is dry, if the patient is on risk for aspiration. You need to have compassion for the patient, okay? So this is NCLEX alert because it's related to safety and it's nursing intervention. Tension and fullness, okay, reflux or aspiration, we have to check for constipation also, which is a no. Under your care, the patient needs to poop, okay, it's very important. If not, we are going to cause more problems in the GI. You need to monitor for pooping. If the patient is having issues, you talk to the doctor. You can decide if you're going to start with any type of enema, or maybe, other type of solution. Also, you need to monitor for diarrhea. Okay, general dissatisfaction with feeding. Yes, I'm getting this, but I really don't like. I need to change the type of food, the type of feeding. Okay, persistent hunger, inability to drink. Think about the patients that are having they are obese, okay, and suddenly they are having a tube feeding, so they feel psychologically that they need to eat more and more, right? So you provide with gum. There are different techniques to make the patient comfortable. So parental feedings, the term parental nutrition refers to any feeding method not involving the GI. We know is going to be through the vein. So you have peripheral parental feeding. The osmolarity of a solution depends on the concentration of its total particles, including dextrose, again, protein, and electrolytes. Small peripheral veins, usually in the arm, deliver the less concentrated solution. So based on the type of tube is going to be the concentration of the feeding. Now, central parental nutritional is going to be appropriate for use when the energy and nutrients requirement is large, or when the client needs full nutrition support for longer periods. That's when they are going to use the central. The surgeon will place the catheter into a large central vein, usually the subclavian vein, that leads directly into the rapid flow of the superior vena cava to the heart. And I don't have to explain this because it's part of your anatomy, physiology knowledge. So parental provides crucial nutrition support from solutions that contain glucose. Again, I am mentioning many times, parental is going to cause hyperglycemia. If the patient is diabetic, that's something that you need to monitor. Probably you need to administer insulin, okay? to reduce that effect. This parental is going to have also amino acids which are required based on the protein that we spoke before. We need at least 9 amino acids, also electrolytes, vitamins, and minerals. Okay, so that's good to know. Parental provides amino acids. Okay, parental helps in the protein support. So here we have a graphic about the cephalic vein, the catheter, basilic vein, in which peripheral parental nutrition feeding is going to be placed. These are the small, the peripheral, okay, parental. And when we are talking about the central parental nutrition, look at this, we are talking about the subclavian vein here next to the clavicle, okay. And also we have another type. We have the external catheter that is going to be inserted through the basilic vein, okay, and is going to go all the way to the subclavian, okay, but this is central parental nutrition. Also, we have another one that is going to be, the tube is hanging. This is the one that I've seen a lot during my bedside nursing. So this is a tube here, and this is the entrance side, right? It's a central vein, and the tube, for this type of tube, we have to be very careful because the tip, okay, can trigger infections. So extra care for this type of parental nutrition, right? Is a tunneled catheter, So these are the propofol drug nutrient interaction. And let's talk about propofol and lipids in nutritional support. Propofol is a fat soluble drug. Remember also your A, D, E, K, your ADEC, your vitamins, fat soluble, vitamin A, vitamin D, vitamin E, vitamin K. Propofol is a fat soluble drug that is emulsified in an oil and water solution for IV administration. During long-term sedation, patients often receive nutrition support in the form of enteral or parental. One important consideration for the nutrition support team is the concurrent administration of propofol because the lipid emulsion contributes to 1.1 kilocalorie per milliliter. Therefore, the registered dietitian will reduce the calories from EN and PM, enteral and parental solutions, to compensate for the calories provided in propofol. So propofol is already giving you fat, so the registered dietitian, since they are providing nutrition, they are going to reduce the amount of fat in that particular formula, right, to compensate the fact that propofol is giving fat already to the patient. Elevated serum triglyceride levels may result in the infusion rate of propofol exceeds the body ability to clear it. That's why they reduce to make a balance. This is more likely to occur with long-term use of propofol when other risk factors are present, like advanced age, cardiovascular disease. You don't want to feed the patient, but at the same time, you're causing problems in the cardiovascular due to the high amount of fats the patient is receiving, right? So the healthcare team is going to monitor the triglyceride levels during propofol infusion to prevent hypertriglyceridemia. Now, cultural differences in advanced care planning. What is important to remember is that people sometimes refer to ENT and PN support as artificial nutrition and hydration. That's why, as we reviewed previously, they prefer homemade puree to have through this feeding. Patients do not always welcome these potentially life-sustaining interventions. For individuals nearing the end of life, artificial nutrition is unlikely to prolong life and even lead to medical complications and increase suffering. So sometimes when the patient is in hospice, they stop all type of feeding, right? Significant differences exist among various racial and ethnic groups and their caregivers about advanced care planning, and end-of-life decisions. So several factors influence the completion of a living will. A do not resuscitate order, this is your DNR, or order that address the removal of life support. So we have to consider the sex, the education, religion, age, and the ethnicity in this when we provided care to patients that are at the end of life, right? In advanced care planning. Okay. So we're going to stop here. When we come back, we are going to speak about the nutrition and needs after gastrointestinal surgery. This is very important. We are going to talk about GERD. We are going to talk about the dumping syndrome, patients that are having the bariatric surgery, right? That is very popular now. And what are the risks and the benefits? Okay, when we come back, more about this.